Thank you very much and welcome. We will wait for a few seconds until all the participants are in the room. Vamos a esperar unos minutos para comenzar hasta que todos los participantes logren ingresar a la sala. El número de participantes inscritos es muy...
The number of participants that have registered is really very big, so we'll wait for 20 more seconds.
Ok. Vamos a comenzar este...
So let's begin this webinar on the updates of the clinical management of maternal sepsis organized by the Pan American Health Organization, PAHO, WHO. We want to welcome you all, and as you join, we want to warmly welcome you. And before we begin,
We want to mention that we will have simultaneous interpretation. Please use the globe and select your language of preference. If all the webinar will be in Spanish, please select English or Portuguese if is that the language of your preference. Please use the chat icon to communicate with us, and you have questions, please use the Q&A icon, and the oral interventions for attendees will not be possible for timing constraints. La siguiente. Esta sessão tem interpretação simultânea. Por favor, use o ícone do globo para selecionar seu idioma.
now he's repeating what he just said in Portuguese.
Mas se tem perguntas, use Q&A para perguntas e respostas. As intervenções orais dos participantes não poderão ser possíveis pelas constrições de tempo. Entonces, con este...
So, with these instructions, we would like to thank the over 2,000 people that have registered in this webinar, and we would like to welcome those who have already joined the room. To begin, we'd like to welcome and have opening remarks. Let's welcome Dr. Suzanne Saroja, Head of Course of Life, Women's Health and Children Health Unit of the Department of Systems and Health Services at the PAHO. You have the floor, Dr. Suzanne. Thank you, Rodolfo. I would like to warmly welcome you all. There are national authorities here, also teams of experts, healthcare professionals, and all those that have a commitment with women's health. And why are we here? Because maternal sepsis is one of the main causes of morbidity and mortality for women, and this happens globally and regionally as well. So we are 4 years from the SDGs, and SDGs 3.1 sets forth very clearly that we need to verify the reason of global maternity mortality. To do that, we need and we have effective interventions on direct preventable causes such as sepsis, and we need to understand that sepsis is a critical condition within all of the global initiatives for improvement in quality of care. So that is included as one of the most important. We have a call to action for a world campaign, which is called World Sepsis Day, and the declaration that sepsis is a public health priority. Why? Because the WHO is working with all of you in order to implement quality standards in maternal um, care that emphasizes two very important points. One, the early detection, and second, the timely management of complications. So, from the regional point of view, I think that you all know about this, and we started in 2024. The director of the Pan American Health Organization, Dr. Jasper Barbosa, has made a call for action to have zero maternal deaths that can be preventable in the region until 2030. We are working on that regional strategy to have an accelerated reduction, and this has been prioritized based on three main axes: the care quality, the timely response to obstetrician emergencies, what we are talking about today, sepsis is an emergency, and also the integration of health care networks. Within this framework, sepsis is a sentinel event that will reflect both the capacity of systems to prevent infections as well as to recognize and timely treat. If we watch this on the perspective of quality of care, maternal sepsis is very closely linked with the dimensions of safety, opportunity, and effectiveness. Why? Because unfortunately, its evolution is fast and potentially lethal. So, we need to reduce the delays from the time we recognize the pathology until we treat. And this early diagnosis has a challenge because there are the physiological specificities of pregnancy, and we have some vital signs that might make it more difficult to understand the early signals of the infection. So that's why it's important to use tools that have already been standardized in order to have clinical evaluation, also alert systems, uh, organ failure scales. Those interventions can improve the quality. And several systems have been proposed to have the early identification of sepsis and also clinical deterioration. The systematic implementations of those tools is aligned with the recommendations of continuous improvement of quality and safety for women promoted by all of us. In this webinar, you will be listening from the best specialists talking about the main concepts, the points of greater innovation, experience developed successfully in several places, because no woman should die when giving birth. And it's our duty from the Pan American Health Organization, based on all the work that we've been developing with the various teams, to work to make that very specific in every woman's life. We want to welcome you all once again, and please enjoy this webinar. I'm sure you're gonna love it. Thank you. Thank you very much, Dr. Seguruga. On behalf of our head of department, Dr. James Fitzgerald, uh, we officially now open the webinar. You'll probably agree that this is a hell of a webinar, so to speak. Those that will be joining us today, as Dr. Saruja was saying, are excellent experts on the topic that have been in the implementation of research to the implementation of public policy. So the goal of this webinar is to strengthen the capacities of the healthcare professional for the early detection, the initial management, and timely management of maternal sepsis in order to reduce morbid mortality in the region. At the end of the webinar, that will be less than 75 minutes, we hope that all of you can recognize the clinical particularities of sepsis during pregnancy and puerperium, that you will be able to recognize and really know about the different tools and early alert systems that identify maternal sepsis in a timely manner, and also be clear about the critical interventions to implement during the first hour of sepsis suspicion, particularly in various levels of attention. I have the honor and the pleasure to introduce you to Dr. João Paulo de Souza, Director of the Latin American and Caribbean Center on Information and Health Sciences, who will be speaking about interventions, multi-component interventions, in order to improve the results of maternal sepsis. João Paulo, you have the floor. Thank you very much, Rodolfo. Good morning, everyone. It's really an honor, a pleasure to be here with you today. Let me begin my presentation by clarifying that I'm here speaking on behalf of many people who have worked really hard to build the evidence and the guidelines that we're going to see. There are people from various institutions and hospitals, organizations, and many of our colleagues from WHO, PAHO, CLAB, that really strived a lot in order to build all of this information. Let me turn off my camera so I can start sharing my screen. Okay, so I'm talking about the reduction of maternal deaths due to sepsis, and let's start with the fact that sepsis is a mostly preventable condition that constitutes up to 50% of intra-hospital maternal deaths. Many times, infections are primary complications, but other complications such as preeclampsia or hemorrhage or the final mechanism of death is produced through infection and sepsis. It's also important to highlight that this is mortality by sepsis, and in different countries with lower and mid-income, um, infection is higher, which contribute to 50% of deaths in terms of intra-hospital maternal deaths, and 11% direct sepsis. So we will start with this 10% as primary complication, but up to 50% of maternal deaths are produced by sepsis. So it's important, and I wanted to start, let's say, by the end of the presentation. There are 3 persistent failures. The hygiene, the hands hygiene, which is inconsistent, the inadequate use or late use of antibiotics, and the diagnosis or treatment of sepsis with a delay. So this highlights the importance in gaps of implementation. Guidelines exist, but its compliance is the problems. So it does not have to do with knowledge, but with inconsistent implementation.
We performed a study about the multi-component intervention based on 3 main components, including hand washing, prevention and treatment of infections using antibiotics, based on evidence and the early detection of sepsis. That was implemented through the institutional finding, people who led the champions of the facilities that were trained, and there was a multidisciplinary training and then a FASTEM checklist, and finally the performance dashboards that were part of the components used to identify where they were in this road to implementation. And so this FASTEM treatment package that must be implemented within the first hour of suspecting about sepsis has to do with the use of fluids. And it's important to clarify, and probably my colleagues are going to touch upon this as well. When we conducted the studies that finally fed this FASTEM component, we used fluids in a more, let's say, liberal way. Now there are more controls about these IV boluses that must be infused, and then the use of antibiotics, broad spectrum, control of the source and the source of infection, eliminating, identifying, and treating the source of infection, transfer to another center, healthcare facility, and finally the monitoring of the patient. We conducted a study that I will cover now in 59 hospitals in African countries, Malawi and Uganda, involving 431,000 women. This was a randomized clinical trial by conglomerates published last April on the New England Journal of Medicine. And they observed that with a systematic implementation of this package, this set of interventions, they observed a decrease of 32% in maternal mortality and morbidity due to infection. So this study was very important because there are very few evidence-based studies that truly show the direct impact between mortality reduction and severe morbidity. More than 30% reduction is a very good figure, considering the interventions that you have seen in very simple treatments. And it's interesting to see the changes made at hospitals, the use of antibiotics within the first hour when sepsis is suspected went from 38 to 44%, a small reduction. Now, checking vital signs on women at the moment of suspicion went from 15% to less than 50%. And the use of antibiotic prophylaxis in C-sections at the hospitals went from 58 to less than 75%. And hand washing in a consistent manner went from 15 to 33%. So this is very important to consider. So the baseline rates of use of this intervention show an improvement, although the adherence is incomplete. But this has caused a huge impact, and the program was able to act on multiple points in these implementations, having a positive impact in the entire care pathway. And I wanted to emphasize these results because there's actually nothing so new, but everything is so important. So APT Sepsis is a program that does not introduce new drugs, new technologies, or new guidelines. It makes sure that what we already know works can be implemented. Hand washing, timely antibiotics, early warning, and fast response performed in a reliable manner. The objective is to close implementation gaps and not invent anything new. And then the change of behavior at facility level, the importance of having champions, leaders, training, feedback. And it was proved to be viable with existing resources in low income or mid income countries. So these champions had a minimum equipment. And for the Americas, the baseline quality may differ depending on the facility context. So this gap may be smaller in some facilities than in others. Now, the question is not whether the problem exists, but rather where the gaps are. Where do we have more space to make a true impact? But well, these are the results of this super study. Now, let me share with you the context and the story behind this trial where many, many people participated. So the first is the political commitment that was obtained and was built during the 90s until we got to the Millennium Goals in 2015. So even though at that time there were 500,000 women who died due to these causes, now we are getting to the end of this process of the Millennium Development Goals. And we must be present to ensure that in the 2030-2045 period, maternal health is still part of the global objectives. And another point is that there is a statistical paradox. Even though 500,000 women, more or less, well, we still have huge numbers today, 60,000 approximately. At individual hospitals, numbers are small. So we are going through times based on feedback. That is when we identified the need to develop the near misses approach. So it's important to mention this approach because WHO is based on the near miss approach that is related to the organ failure aspect. So we need to think about organ failure as a marker to consider actions for the benefit of eradicating sepsis. That was a very important piece that was found and identified, and it was part of the results assessed during the study, this severe organ failure associated to sepsis. Another study, and I'm sure many of you participated in this around 2010, the multi-country survey about morbid mortality that assessed the complications and the interventions. And that was when they identified that there was suboptimal care for sepsis. So in 2015, due to these findings, WHO and PAHO developed a regulatory framework including these components: hand washing, antibiotics, antiseptic preparation, and infection treatments. This was a global guideline that was later on implemented. But that was when the sepsis definition was changed globally to talk about maternal sepsis as a potentially lethal condition that results from organ failure caused by infections during pregnancy, labor, post-labor, or periods. They mentioned the difficulty to identify the inflammatory response symptoms, so on and so forth. All of the signs related to pregnancy. But this was so important, not just a semantic exercise, but rather the basis to build the next steps. And again, this was based on an international survey, consensus meetings, and systematic reviews. Another study that you may know and probably participated in is the Global Maternal Sepsis study that presented very important results to quantify that around 50% of maternal deaths, regardless of the primary cause, end up in infection or sepsis. The Argentina, Bolivia, Brazil, Colombia, Ecuador, Guatemala, Honduras, Mexico, Nicaragua, Peru, and Uruguay participated in this study. A study that was carried out in over 700 hospitals in 52 countries. In the Americas, around 12% of women with infection developed a severe maternal outcome compared to almost 20% in Africa. And it's important to clarify one point here. We have the guidelines, we have the packages, and we have implementation programs. So guidelines include recommendations as to what steps must be taken. And the care package defines the critical clinical steps that must be taken with synergistic impact when applied together. This is what we saw after the study, how small implementation changes are important, but what's more important is the combination of those steps and the prevention as well. This causes a more significant impact. So the package, as I said, and the implementation program, that is to say, how the guidelines and the packages must be implemented in a more effective manner, including the use of institutional champions or training sessions and tools and the dashboards and the feedback system. So when implemented all together at the same time, we are able to make a stronger impact in the culture of the facilities. Well, that was the WHO PAHO guideline of 2015 that was later on translated into the FAST-M package and the APT sepsis program. So we took a long path from the building of the bases to the testing and randomized control trial. The first person that was recruited was in November 2022, and we completed this step 2 years later until we got to this publication. So let me tell you about the clinical trial. This was a randomized trial with 2 arms, 59 hospitals, 30 from Malawi, 29 from Uganda, that provide integral healthcare with a recruitment of 430,000 women and 290,000 in the baseline phase, 240,000 in the intervention phase, and there are some specific details on the publication.
These are some of the details showing the reduction of 30% in the primary compose results. So the path, this is my last slide. I think that evidence is well established. Reduction of 32% of maternal mortality and morbidity is possible, and this has been proven in over 400,000 women. Tools exist, training material and interventive packages, and this model of implementation based on institutional leadership like champions the use of institutional performance dashboards. And there are also challenges right now. The main challenge is adaptation and scale in order to have an impact, and also the importance of the local contextualization. Something important also to highlight in the case of Americas is to identify the most important gaps. Here, we focused a lot on what we believe were global issues during 2010 and 2015, because this is when the study was generated around hand hygiene, use of antibiotics, early alert, and fast response. There are some differences in the Americas, so it's important to intensify actions in order to produce a more effective outcome. So with this, I conclude my presentation. You will also have all the references that are included in this presentation. And let me thank you for the opportunity of being here with you. Thank you very much. I think you all agree with me that this was a brilliant presentation. Thank you very much, João Paulo. It was a brilliant summary of a long road, both professionally and institutionally. Thank you very much. So now we'll continue with a very interesting moment at this webinar that will be coordinated by Dr. Claudio Sosa, who's an international consultant of the Course of Life Women and Children's Health Unit from PAHO, who will be moderating this questions and answers session with two experts that are absolute leaders on the matter. So let me give Dr. Sosa the floor. You can introduce your panelists. Good morning. How are you? Thank you very much, Rodolfo. Thank you all. It's a pleasure to be able to be part of this webinar. An excellent presentation by João Paulo. And now we'll have some questions and answers with a team that we've been working with for a long time, you know, from PAHO, the Latin American Center at the very beginning, and now from the women's units. We are working on obstetric emergencies for many years. And remember that in 2015, based on maternal death by hemorrhage, we worked on zero maternal death by obstetrical hemorrhage. And this made us work a lot with countries, but it also took us to work on other emergencies. We know that we need to implement actions in order to cover all sorts of emergencies, hypertension, hemorrhage, and in this case, sepsis. So in that second stage of zero maternal death, we worked specifically, and João already talked about the GLOSS study from WHO, where he highlighted that infection was even more frequent than what we thought, that deaths did not happen in high-income countries, and low-income countries had poor vital registries. They were very poor, and that was the most important thing on how to face an improvement in detection, and also fast action in the case of sepsis that evolved so quickly. At that time, the experts we've been working with were the ones we have today, but there are many other collaborators. In the case of Dr. Jose Antonio Rojas, professor of the postgraduate program of critical medicine at the University of Cartagena and director of ICU at the ESE, also the maternity clinic Rafael Calvo in Cartagena, Colombia. So particularly our friend worked on the module of the sepsis station together with some other professors as Maria Fernandez Cobar. And we started questioning about the actions that we need in order to have a quick detection and also a fast action. We have also with us another great friend who also participated at all times with Zero Maternal Death by Hemorrhage, Dr. Mauricio Vasco. He's coordinator of the Obstetric Anesthetics Committee at the Latin American Confederation of Obstetric Anesthetics, CLASA, also professor at the University of Medellin, Colombia. In this case, we wanted to validate to have something very well standardized with all the components that were mentioned by João Paulo. And right now, we want to show you part of all this knowledge based on a series of questions that we prepared, and we want to share with you who are part of the management of obstetric sepsis. So let me share my screen with you. We will begin with Joche, with Dr. Rojas first. And the first question in relation to what João Pablo was saying about the progressive definition of sepsis, remember that it was not in pregnant women, but it was rather applied to the general adult population, but not specifically to the pregnant women. And this progressive definition in various studies, sepsis 3, and then some other modifications. But we understand that currently there is a global consensus on maternal sepsis. So I would like Jorge to talk a little bit about that definition of daily practice for the clinician. So first of all, I would like to greet all of those who are joining from Latin America and the rest of the world. And the answer is that today there is a consensus on maternal sepsis, and we could define it very simple, in a very simple and specific way, as a condition starting from the principle of what Zane mentioned at the very beginning. This is a condition that could potentially be mortal. There is also background here. There is a characteristic, which is the organ failure caused by an infection, and this is the obstetric connotation that may appear during pregnancy, during labor, puerperium, or after an unfortunate event as a miscarriage. So the important thing here in this definition is because it takes us away from that old vision that was mainly focused on whether if there was any fever, there was leukocytosis or inflammatory criteria, what you were talking about, the exclusive series. And now it takes us to a more clinical and a safer proposal, which is an infection plus organ failure. So in other words, I think that a patient may have an infection, not be septic. That's the most common thing that we find. But when that infection starts compromising other organs and threatening perfusion, what I was just saying, and starts having near mixed criteria, that's when we are facing an emergency, which is time dependent. And let me highlight the time dependent aspect because we're also going to talk about this with Mauricio. I would summarize the definition in 3 messages. First, not every maternal infection is sepsis, and localized infection should be properly treated, but the word sepsis implies something else. It implies that the response of the patient to that infection is leading to vital risk or failure. The second message is that we should not wait for shock in order to act. This is one of the big mistakes we commit. We should be clear that septic shock is a more advanced and more serious phase. If we wait for deep hypotension, having a patient with vasopressors, or having markers such as lactate or organ failure, or being in the ICU to say that this patient has maternal sepsis, it's very likely that we are already late, particularly in pregnant women and in the or during puerperium. Organ failure might be very subtle. We'll see about that later on, and it encompasses all organs and systems. So the other message is that that definition should not be one to include in a medical record, but it should activate a response. It cannot delay it. And here's where we have some limitations in the resources. I have little resources. The risk is that the definition might become more academic, but the clinical team trying to find this definition might take too long. I think that sepsis continues to be technical diagnosis. There may be no fever, maybe the culture are negative, and the foci is evident as a clinician. So if we have a woman that's pregnant or during preperium and we suspect infection, then I think that we should have an organized and early behavior proportional to the risk that we are observing, particularly in Latin America or mainly for middle or low income countries. The practical question should not only be whether they comply with the criteria, but the question should be, Claudio, whether this patient with an infection, is she showing some signals of failure, and should I act immediately? And so I would like to close my first intervention with this. If I had to leave you with an idea, this is the one. Maternal sepsis is an infection with organ failure, but it should operatively work as a clinical alarm, an alarm that sets off an immediate evaluation and monitoring, search for the foci treatment, and also have an adequate scale, which is what Joao also mentioned during his intervention. Great, excellent, Jorge. So considering that most initial sepsis studies were not on pregnant women, then the next question in line with this reasoning is based on this definition, what are the three most important aspects we need to know in order to differentiate in the clinical practice the physiological changes that we know occur during pregnancy and the organ failure associated to an infection? Well, Claudio, I think that this is one of the most important questions. Zane also mentioned this at the beginning. The pregnancy modifies physiology and it makes it more difficult to recognize sepsis in an early manner. So these three aspects that you've just mentioned, I would summarize them in the fact that I need to know about the physiology. I need to be capable of identifying organ failure and also be able to interpret. And this is something that I always try to teach my residents and my fellows, which is interpreting the clinical path. So first of all, we need to know that pregnancy generates physiological changes, and those changes, such as the increase in the heart rate or the increase in the heart spending or reductions in the vascular resistance, physiological leukocytosis, and some blood changes might be deceiving at the very beginning. But if we use all of those criteria transferred to the non-pregnant population, it is possible to over or underdiagnose the seriousness. So it's important that even though a normal heart rate might be normal or a leukocytosis might be expectable in this patient, and a creatinine that for the general population is normal, maybe for a pregnant person might be abnormal, that makes us somehow be more cautious of the physiological changes in pregnancy. Second, organ failure might be subtle, as I said before, and it does not always start with low blood pressure. And this is key because the absence of shock does not rule out sepsis. And I think that in practice, we need to worry and as we can see in the slide, about that patient with an increase in a sustained increase in heart frequency and respiratory frequency that requires oxygen to reach the adequate oxygenation thresholds. If there is a reduction in the saturation or alteration in the mental state, reduction in diuresis, an alteration in perfusion, all of that allows me to quantify the renal or liver failure or coagulation. So in other words, I think that we need to look for signals of vulnerable organs and not just the classical signs of infection. And third, the trend is generally more important than the isolated value. What do I mean? While pregnancy changes values, sepsis changes the path. And this is key. A patient that is breathing faster every hour, that requires more oxygen, that urinates more with more difficulty, or has a progressive reduction of the its volume, that I see that there is a deterioration from the maintenance point of view, and this cannot be interpreted as a normal variable of the pregnancy. I think that this is one of the most important messages, because when we take this to practice, it has been what has helped us most. So clinical path is a very important tool in order to have diagnosis, particularly when my resources are limited. I think it's fundamental to close this. What's fundamental is the infection foci and the obstetrical moment. So the context. So if I'm in a pregnancy or during gestation, probably infections are related with pyelonephritis, pneumonia, or chorioamnionitis. If this is post-miscarriage or during the presence of an early termination of the pregnancy, I must think about a pelvic infection, what we know as septic abortion. And if it's postpartum, maybe I should suspect whether it's endometritis or infection of other sort, perineal infection, etc. So if this is puerperium, fever and deterioration should also be present, because even late urinary infection or endometritis could also be the cause of this. So to summarize, differentiating between physiological part and failure does not depend on having a number, knowing a number by heart, but understanding the context, recognizing the affected organ, and also looking at the evolution. Let me put it this way. We should not normalize deterioration for the fact that the patient is pregnant, first of all. Also, physiology explains adaptations, but it does not explain hypoxemia or confusion, oliguria, or poor perfusion. That's why I think that we need to be very careful in evaluating progressive deterioration.
Excellent. Thank you very much. Thinking about this path, we need to be aware of the tools available for early detection. What recommendations could be made to implement these tools effectively at different care levels? After the interventions that we discussed, and particularly what Joao said, the most important recommendation is that we need to understand there's no perfect tool. No tool should replace clinical judgment, and early detection stages are subtle but work successfully when we are able to adapt to the context and the level of resources. So I would split it into 3 implementation levels. The first is very, very important. This is the community level, the first contact that must be considered. Low complexity as we know it. There will be no labs, there are no lactate or imaging. So detection must be based on risk signs. So the question should be, do we suspect infection? Do we perceive severe signals if there is a temperature, fever? What about the patient's appearance? What about the respiratory pace of the patient? Is the patient confused? Does the patient have heavy smelling discharge? So these are very, very valuable questions for early detection. So the key lies on detecting and the severity of those signs and symptoms, and try to scale up little by little. Now the second level, mid complexity level, that is universal to Latin America, we must have a systematic vital sign measurement at this level. So I want to call on low complexity levels. Of course, the GLOS study showed it as well. We do not take vital signs globally. We do not take the heart rate globally. So respiratory frequency or respiratory rate and the mental state are key because this will determine the outcome of the patient. So it's very important that at this second level, we understand that there are simple terms that allow us to classify severity. So if I have infection, but I don't have any apparent failure, I might suspect sepsis with these tools. And this will also be very important to define whether we need to go to a higher medical activation process or not. And the third level, which is high complexity and critical care, well, is related to quantifying the organic failure through bilirubins, platelets, creatinine, liver function, oxygen measurement. But even at this level 3 complexity, the message must be the same. The labs will never replace the importance of early detection. So the tool must be chosen according to the moment. There are some studies that say that if we are within the 20 weeks, the tools adapted to the physiology of pregnancy will work best. But if I am very early in pregnancy or far away from puerperium, these adjusted tools may fit best. Rather than imposing a single global scale, every institution should try to implement their protocols. So we need to avoid two errors. First, using very, very sensitive tools if we don't have response capacity. This is what we need to work on in quick response teams, what we call the fatigue of alarms. And the second error is to use too strict tools. Detecting too late could be the failure that we detected and to find the point of balance. So we need to little by little understand the severity and the escalation path. For Latin America, the message should be not all levels have oxygen metering or lactate, but all levels must be capable of identifying deterioration. Early detection must help us identify severity with the resources we have and escalate the patient before organic failure appears. Excellent. Thank you, Dr. Jose Antonio Rojas. We are going to have questions probably. We may not have enough time, but all questions at the end can be made. And now we go to our friend Mauricio Pasco. Mauricio, we know that we talked about delay in treating sepsis. The more or the longer we take, we know that for every hour, there is an increase of 8% in maternal death. So the question is this. We know that the first hour is crucial to detect maternal sepsis. So why is this first hour so critical? Thank you, Claudio, for your question. And I take this opportunity to say hello to everybody. Sepsis kills. And if we delay the process, the patient is exposed to organic failure, and that patient will end up with complications at the ICU or at a hospitalization at a different hospital. So there is evidence showing that if we are able to implement a pack of interventions within that first hour, mortality can go down by 30%. This is no longer assumptions. This is a clear standard. In addition, the delay in implementing these packets in these multiple intervention strategies unfortunately increases mortality by 10% for every hour that passes by. So in the light of such a robust evidence, we need to change our attitude, allowing every healthcare professional that has contact with these patients can trigger early warning signs. And it's important to create a mental map saying this is the 0 hour for diagnosis. So from now on, I need to implement management strategies that I can be capable of responding to. And try to have the peace of mind that when the hour is over, all the elements that I'm going to touch upon now have been met. So I encourage everybody to see this like a race for life and not think that, well, maybe yes, maybe no, this should be sepsis, this should not be, but rather take all actions in favor of the patient to be wrong if uh, necessary, but always in favor of the patient. So just by implementing simple measures. Good. So at community level, and if we suspect sepsis, what would be the recommendations to take? The three most important recommendations to start the initial management of the patient until we refer the patient to a higher complexity institution. Good. So if we go back to the table that you showed before, this is a table that with very easy to implement signs, and we do have the monitors available, we can identify with color coding each definition of which parameter is altered. So considering this alert system and documenting the hour, there are multiple packages globally that talk about treating patients within the hour. And also in severe preeclampsia, we have 1 hour to stabilize the patient. And when we are treating patients with coronary complications or pulmonary complications, we need to take fast action. So if you think this is just a mental map for all emergencies, actually, for our patients. So the use of fluids, crystalloid solutions, saline serum, Harman solution, but not dextrose components. We might use dextrose thinking that the patient may be low in sugar, so on and so forth, but this is not the same thing. I repeat, saline bags or crystalloids. In 250 ml boluses, offering 500 ml that used to be frequent may cause harm and they are not necessary. And the presence of severe preeclampsia, well, this is not infrequent, and these volumes may worsen the patient's pulmonary involvement. So after applying this 250 ml of crystalloids from 10 to 15 minutes, we need to examine the patient again. We need to see whether the patient feels better, whether the heart rate is normalized, whether she is more rosy in her cheeks, so on and so forth. And then per every crystalloid bolus, we need to apply a dose that allows us to see the response. And so 2-3 boluses will indicate a favorable result. Next, we need to apply antibiotics, broad spectrum antibiotics. We can talk about combinations in a minute, but you need to have a protocol that covers an obstetric infection. Think about the source and take a look at this strategy. This is a great mental map. Try to look for signs on the pelvis, on the chest, on the perineal line, on the C-section area, and try to identify other systemic components. But at least you'll be guided to identify the source. And depending on where we are physically and geographically located, then we need to consider transfer. We cannot paralyze. When we know that the patient is severe, we have 1 hour only, remember, to make these simple interventions. And that is fundamental for the initial management. And we will see that fortunately most patients will be able to recover or normalize. Thank you. So at community level, you talked about how important this is, right? To recognize the presence of infection, looking for care, of course. This is very important. Prevent progression of severity and get organized in order to refer the patient as soon as possible to a higher level.
Now, in medium complexity facilities, what would be the three key recommendations in line with what we were saying before in order to start the management of maternal sepsis, Mauro? Yes, Claudia, the same FAST protocol, but in medium complexity has decisions to refer patients to a higher care facility. Second, the capacity to see whether the foci can be drained. One thing is to cover it with antibiotic, but some infections need to be evacuated, so an intermediate level can already have a surgical response facility in order to drain this foci. And additionally, in thinking of referrals, intermediate levels are fundamental to see whether these patients can be managed in this place or whether they need to be referred to a higher complexity level to do so. So the responsibility of intermediate level is important because they need to have a resolution capacity, a human talent with capability to make those decisions. And particularly in this question, I would say that we need to generate capabilities of surgical resolution in intermediate levels, particularly in order to continue with reanimation processes and also the drainage that many times makes our patients be referred, and that could have been done in that intermediate level. Excellent. Thank you, Mauro. So clearly, as João Paulo was saying, sepsis, while we know about this and changes in medical intervention for sure, a great part of it continues to be the organization of the system to provide a good response. I mean, an early detection and a fast response as soon as possible. This is something that we need. There are no new technologies. Antibiotics are probably the same. Fluids, something has changed, but and we might have more specific management, but in general, and this is what we always promoted in workshops, it has to do with the organization of the site of community and institution in order to provide an early detection and an early response, and obviously the referral system and the control of it, which is fundamental. So Rodolfo, these were the questions that we wanted to have an answer to, and thinking about the community and thinking about intermediate complexity facilities, but also with a view and considering new evidence to see how to give a better response. Maybe there are some more specific questions right now or something to talk about more specifically with our experts in relation to all of this. I don't know if the audience has written any questions on the chat. I know that we have many participants. Thank you very much, Claudia. Thank you very much to the panel. I invite João Paulo to turn on the camera. And now let's reaffirm a little bit the objectives of this webinar. And Mauro, there is an insistence on a question from a colleague from Brazil on the need for hysterectomy when there is sepsis with peritonitis. So maybe we could start by there. You mentioned something during your presentation. So you have 1 minute, just 1 minute to answer whether is it necessary, essential, mandatory? This is the question. So if you could answer to that. Well, Rodolfo, this is a decision from the working team. From the anesthetics perspective and ICU, we call the obstetricians and we tell them that there is a patient that's refractory to reanimation measures after resuscitation with fluids and using vasopressors and assessing the reanimation components, the lactate, ring, and everything is still high. It's not just a hysterectomy. Maybe there is some foci that is not being drained. Maybe the patient has a complicated urinary infection, or maybe a complicated pneumonia, or an obstruction in the kidney, or an intra-abdominal abscess. So as a support group, we provide the tools to the team and tell them that reanimation strategies are not really working. Maybe the focus is not really well covered or not drained, and together with surgical specialties, maybe we need to do that. So not a routine hysterectomy, and we need to evaluate according to the context and what to see whether the focus has been really covered by antibiotics or not drained. Maybe they need some surgical percutaneous interventions. And now another question. Thank you very much. But another question that has also emerged in the questions that were sent prior to the webinar. This is a very specific question. Which vasopressor, according to scientific evidence, do you recommend to use during the first line of treatment of maternal sepsis in a pregnant woman? What would be the recommended vasopressor in the first line of treatment? Let me start, and I can open the space. Guidelines indicate that we should start with norepinephrine titer to have response which is over 65,000 m of mercury. But in this case, we need the vasopressor that is necessary in order to obtain the goal. So we would start with that indication, and let me open it up for the rest of the panelists to define how to scale this and which route to use. I support Mauricio's answer. And let me just add something else, which is really very important. You need to identify whether that vasopressor has more general applicability profiles. For instance, some vasopressors have almost null evidence of its application through a peripheral route. So if we want to consider a general option, a first point, which is also important, is whether this vasopressor could also be administered peripherally, understanding that it requires different concentrations but not a greater complexity. And if that's the case, the evidence we have today is by far favoring noradrenaline or norepinephrine than any other presentations of vasopressors that we know of and that are available. So I think that is also something that we should take into consideration, the route of administration and the safety in its use. Thank you very much for the clarity. And last question in our last minutes is how to better organize the attention in order to answer to this need of early diagnosis and timely treatment of sepsis in a healthcare system. João Paulo. Thank you very much. Well, first, I think that continuous care is ideal. So we should recognize whether this is primary, secondary, or tertiary level, and as soon as possible, we should recognize that and make sure that that woman reaches the necessary level of care. If they need to be referred, okay, and during transportation, also the necessary support. Second, maybe there are a few studies that prove a direct impact on maternal mortality. One of those confirms this sepsis. It has to do with local committees and leadership institutions. So we need to have champions in those cases to reduce maternal mortality and improvement in care. So based on that, we can implement the different interventions we may have. Thank you. Thank you very much for respecting times as well. And in relation to respecting the total time of the webinar, and after thanking each one of you, Claudia, Mauricio, Jose, Joao, we will invite Dr. Susan Cerruja, our head of unit, to close this webinar. You have the floor, Susana. And before we conclude, let me also thank those who have made so many questions, and be sure that we will answer to all of them, and we're going to share this recording with the associated documents. If this is the answer for those who are asking in the chat, you will all get the information. Thank you very much, Suzanne. Thank you, Rodolfo. Let me start with that, with information. And there is a very important QR code to share with you right now. That QR code has direct link to fundamental importance course for what we talked today. So we will see what were the terms that were mostly mentioned today. Clearly, we will see a continuous care. Care cannot be periodic. And women are having less amount of children. So labor is a transcendental moment in life. So this woman deserves all the care and surveillance that is needed. You've heard from the very beginning, and it's also been one of the last remarks made by Paolo. Thank you, Joao, by the way, for your presentation and for your participation. When we see, I mean, there are things that are quite simple and we need to do increasingly more, like washing our hands. So care and care to evidence that we already have. And why do we consider that this is simple? Well, they are simple, but many times we do not provide the necessary care. The second term that has been mostly repeated today, please, if you could leave the QR code on the screen. Near miss. The near miss in maternal morbidity is the future surveillance of women's health, because we hope there are no more maternal deaths. We hope that maternal deaths are so rare that we won't have, like in the case when I was in Cuba, I visited a hospital where for 7 years no women had died there. But this course that we have in this virtual campus is free of charge. This is a virtual course on obstetric patients that are critically ill. And here we have the participation of specialists, our collaborators like Dr. Mauricio Basco, our Mauro, always with us as well, Jose Antonio Rojas, and Claudia, of course, our international consultant, who led together with this team in several countries. He's been leading these courses. So now we have a free virtual course. As you can see, as Rodolfo just mentioned, you will all receive these presentations and the links, and you will be able to invite your own teams. We spent almost 1 hour here and we talked about a fundamental thing. We heard fundamental things. We've seen studies that finished 10 years after they started. So this is my message to you. We have tools, we have evidence. What do we need to prevent women dying from sepsis? Implementations of fast actions, observation, better care. So today, I want to leave you with that reflection on how we can engage professionals and every team member for this care, which is so important for women in this very transcendental time. Maybe once in your life, once in their lives, or twice in their lives. So we still fight for women's life. I cannot end this meeting without thanking all of those who are behind the scenes, as Monica Chu, Rodolfo Gomez, who's our regional advisor in sexual, reproductive, and maternal health, who have organized this meeting. They have brought very important questions and will also continue with a follow-up of this webinar. So thank you very much. And thank you all. Thank you to the whole team, interpreters, Brenda, who's coordinating the Zoom team, and also our journalists, all of those working behind the scenes on behalf of our director, Dr. James Fitzgerald, and on behalf of myself. Thank you so much for your participation today. And I'll leave you with this QR code, and register is free and we'll make it. Thank you.